Okay, I'll start now. Okay, thank you everyone. Thank you for joining us on this Spondylo-Arthropathy update 2020. This is a Sunday evening, we all know. Thanks for taking time out to join us. We especially thank the entire team of Novartis to organize this meeting. We know that spondyloarthropathy is a challenging disease, quite a bit of challenge to manage. Early diagnosis and institution of right treatment is essential because it can cause significant damage. It can cause quite a bit of financial loss as well because they're taking quite frequent time off work. There's a bit of a emotional, like a lot of depression because of the pain, a lot of other psychological issues. We have two very experienced and eminent speakers with us today. Dr.S.Ramakrishnan is a consultant in Apollo Hospital, Chennai. He doesn't need any introduction. He's one of the leading rheumatologists in India, and he has a massive experience in rheumatology, especially in spondylo-arthropathy. We would like to share his experience so that we can learn from the four. Our second speaker is Dr.Abhra Chowdhury. He's a young and budding rheumatologist in Kolkata. He's very highly qualified. He has done DM from SPGI. So I'll come back to you in a minute. I can see there are a few MD, BGTs and non-rheumatologists in the group as well. So I'll skip some very short presentation with some introductory slides just to make them aware what we're going to deal with. My slides are not moving. So that's myself. I'm Dr.Parthajit, consultant rheumatologist.
Welcome to our music world. Ready to tear.
So just to give an idea, what is spondyloarthritis? There includes a group of disease. It includes ankylosing spondylitis, reactive arthritis, psoriatic arthritis, enteropathic inflammatory arthritis, juvenile spondyloarthropathy, and undifferentiated SPA. These are old cartoons, but the newer varieties, they have differentiated into axial and peripheral spondyloarthropathies. So axial involves and spawn, which is they have bony changes and non-radiographic. I've got one slide for that. And the peripheral arthritis, peripheral spondyloarthritis includes psoriatic arthritis, reactive arthritis, etc. But in all these subgroups, if they're associated with HLA-B27, the chance of getting inflammatory spinal disease or axial spine is quite high. So just a slide on axial spondyloarthritis. We all know about the modified NEO criteria, which was devised in 1984. But in that criteria, it has mentioned patients with inflammatory back for more than 3 months. There are a lot of limitations of the spinal movement, limitations of the chest movement, and they have grade 2 sacroiliitis. Having said that, when somebody has reached that stage, it's quite advanced and spawn. So there's no point in return, and very limited things we can offer at that stage. But the whole concept has changed now. So very early stage is a non-radiographic stage, which progressed to develop a radiographic stage. So in the non-radiographic stage, patient will have a lot of inflammatory symptoms. If you do an imaging like MRI scan of the sacroiliac joint, the stir will show bone marrow edema, but the X-ray will be normal. There will be no bony involvement. So that's early stage. If it's not treated or detected early on at that stage, that will begin to develop a radiographic stage. That means they'll have MRI scan changes and the X-ray changes as well. And if it's not treated, they can develop a lot of cinder snophites and bony fusions. And at the final stage is the bamboo spine, which we all know. So that's the same thing which is depicted early in non-radiographic stage. If you can see my slides and the cursors as well. A lot of edema around the sacral side of the sacroiliac joint and the ilium side as well, but the sacroiliac joint is quite pristine clear. Whereas in radiographic stage, you can see sclerosis of the iliac side of the sacroiliac joint. So that means the bony damage and bony erosion changes has started to happen. And if it's not treated at that stage, that will progress to develop radiographic quite advanced, which is the bamboo spine. All the cinder snophites are there. So a lot of debate about spondyloarthropathy. I'm not going in details. So there's a debate about how to diagnose inflammatory back pain and how to diagnose spondyloarthropathy. Dr. Ramakrishnan is going to delve into it a bit more details. So ASAS criteria has come up with the inflammatory back pain diagnostic or classification criteria. So when the age is less than 40, insidious onset, which improves with exercise and doesn't probably gets worse with rest, and pain gets worse at night time. So this is roughly ideas. It's mainly for the non-rheumatologist audience today, and that will give us some more clues about more confidence in diagnosis of inflammatory back pain. There's a lot of delay in the diagnosis because patients not always come to a rheumatologist. They either go to a physiotherapist or orthopedic team or neurologist for the back pain, and often get delayed. So there's a bit of doubt about the HLA-B27. There's almost 222 subtypes. Not all the subtypes are pathogenic. HLA-B27 06 and 06 is not causing unspond really. And if you look at this cartoon, there's a prevalence of various subtypes in various continents. Like 05 is more prevalent in Africa, 02 in European countries, 04 in Asian, Eastern Asian. This is more in the Middle East. So if you ask everyone about if you have HLA-B27, whether you're going to develop spondyloarthropathy, is around 2% of patients who have HLA positive status, they will probably develop ANSPON at the later rate. And if you have ANSPON, around 10% of the next generation will be affected. But this is just a general rule. If you have like SEC16A gene, the inheritance is almost 100%. And because of more sharing, monozygotic twins will be more affected compared to the dizygotic twins. And first degree relatives will be more affected than the second and third degree relatives. But having said that, HLA-B has a protective role as well. They also protect someone from hepatitis C and HIV or a very complex reason. But when you have someone even with HLA-B27 positive status, if someone has asymmetrical unilateral secularitis, you have to be careful in Indian subcontinent. You have to exclude any infections, tuberculosis, or other cause of asymmetrical secularitis. And in terms of treatment, unilateral NSAIDs can be there. You can use biological treatment, which is a matter of debate. It depends whether other extra articular manifestations are there, like dactylitis, tendinitis, or enthesitis. If it's one joint, individual sacroiliac joint is often helpful, often quite helpful for the patient. Smoking is a very strong association with progression of disease, so that has to be, the patient has to be educated adequately so that they can stop smoking. There is no strong evidence whether diet modification is going to help. There's significant role of exercise, so you need to combine not just the spinal mobility exercise, they have to also do cardiac exercises, aerobic exercise, and muscle strengthening for the better outcome. Again, there's a debate about NSAIDs, which one is better. There's no significant kind of research data saying that one is more efficacious than the other. There's again debate about whether continuous NSAIDs is better than on-demand, but recent studies are showing that on-demand is equally good when compared to the continuous NSAIDs. You can use anti-inflammatories up to 6 months, but you have to be careful about the side effects as well, like GI side effects, nephrotoxicity. There are some few interesting papers in the past that a continuous anti-inflammatory treatment can have some disease modifying effect on the spine. But again, be careful about kidney patients. So paracetamol is safe. Etodolac is probably safer than rest of the drugs. You have to pick and choose and individualize the treatment plan. I'm not discussing the role of biological treatment because Dr. Chowdhury is going to deal with that. Again, in COVID scenario, it's quite a bit of challenge whether to use, not to use the biological treatment. If you look at the BSR, EULAR, ACR guidelines, it's been advised to continue the treatment at this point because if the patient is actively affected with the active disease, that needs to be controlled first. But if they have active infection, you can always stop or defer the treatment for a few weeks or so. But again, that has to be individualized. The role of surgery is very limited evidence, but if someone can look front, if they're kind of training of the neck, if they're difficult to look up, then probably there's an indication, but otherwise there's not a major role. So rather than wasting more time, I would like to go straight onto the first talk. Dr. Ramakrishnan is going to enlighten us on ankylosing spondylitis, a rheumatologist journey. Over to you, sir. I'm just unsharing my screen.
Shall I start?
Just a minute, I think they're probably checking. So I think you can start now, sir.
Yeah, thank you. Good evening, my dear brothers and sisters of America. I think all of you remember the statement said by Swami Vivekananda when he went to the World Parliament of Religions. I am proud to speak to all of you today, this evening, especially to the soil of Rabindranath Tagore and Sri Ramakrishna Paramahamsa and Mother Sharada Devi. I am a strong devotee of Sri Ramakrishna Paramahamsa and Sri Sharada Devi. I thank Novartis also for giving me an opportunity to be with the elite rheumatologists of the Northeast. My talk today is ankylosing spondylitis, a rheumatologist's journey. Next slide, please. Now, one thing which is very important is that in 1983, I entered the corridors of Government General Hospital as a fresh MD postgraduate student, doctor, and entered the corridors of the rheumatology department. I knew nothing of rheumatology at that point of time, except that what I read in Harrison's textbook of internal medicine. Next slide, please. Now, it's very, very interesting journey. With absolutely in a trolley, crippled. And he was from Andhra Pradesh. I didn't know what it was. I tried to examine him, but he was as stiff as nothing. A stiff man came like a robber. I did not know what the disease was. My colleagues taught me what is ankylosing spondylitis, and I thank all the people who have thanked me in Government General Hospital, Rheumatology Department, General Hospital, under the able leadership of Professor A.N. Chandrasekharan, who is my mentor and guru. And that was the beginning of my journey. Making a diagnosis of ankylosing spondylitis then was a diagnosis of pride for me. I have read it in Harrison's textbook of internal medicine. But what a misery it was for patient. A diagnosis of pride, which fulfilled my ego, but I could offer only my sincere condolences to the patient because I had nothing to offer him for treatment other than non-steroidal anti-inflammatory drugs, but was nothing but a textbook translated into reality as far as I was concerned. Next slide. This patient complained of low back pain since 12 years. Somebody has to be muted.
I think sir is muted.
বলতে হবে মিউট হয়ে যাচ্ছে
আমি এখান থেকে মিউট অন করতে পারবো না
I think sir probably have to unmute yourself. We can't hear you.
Can you hear me now?
Yeah, I think you're audible now. That's fine.
I have the greatest disadvantage that I'm speaking from home. So I cannot speak for more than 5 minutes at home. That's why automatically it got unmuted. Now I'll mute. So syndesmophytes, bamboo spine, and non-existent sacroiliac joints were as common as the common cold. Next slide, please. 1984. No spondyloarthritis then, but AS then. Crippled physically, disabled, depressed, a delay in medical consultation by 10 years to 12 years. Investigations primarily were hemogram, biochemistry, and radiograph. So this is the origin of ankylosing spondylitis. You see, this is the origin of the Ganges at Gangotri. Management of ankylosing spondylitis in 1984. What could we offer? No holistic management. Medications were non-steroidal anti-inflammatory drugs like indomethacin, ibuprofen, naproxen, diclofenac. My God, phenylbutazone was just used like mineral water then. To modify the disease process, we offered conventional DMRD like sulfasalazine. Later what happened, the effect of methotrexate and rheumatoid as a DMRD was extrapolated to be a DMRD for ankylosing spondylitis. So we offered two medications for patients with angspon, sulfasalazine and DMRD and methotrexate. Physiotherapy was absolutely primitive in 1984. Just stretching exercises, swimming, breathing exercises. And swimming is very easy in Chennai, especially during the rains, because there was more water to swim than to drink at that point of time. Next slide. The conventional synthetic DMRs. Time moved on, and I was there in H.G. Wells' time machine in 1984, going on to the late 1890s. Sulfasalazine and methotrexate have not been found to be of therapeutic value on axial disease now. But sulfasalazine still holds its place in controlling the peripheral polyarthritis of spondyloarthritis. People can still stir the hornet's nest and tell me, well, sulfasalazine seems to be useful in axial arthropathy because you take the poor patient with spondyloarthritis, he cannot afford a biologic, so we give a trial of sulfasalazine. Nothing wrong in giving, but science has proved that it is not very useful. The 1990s NSAID story. Concept of holistic treatment was a dream. NSAID-induced nephropathy and gastropathy came to light. Long-term NSAID intake, people landed up with chronic interstitial nephritis and NSAID-induced gastric ulcers. Patients, in spite of counseling, could not accept the disease process and they went doctor shopping for a miracle. Steroids were used to give symptomatic relief then, but at present, we do not give steroids to patients with ankylosing spondylitis other than giving intra-articular injection. So this is the NSAID story. Next slide. And the other important point is the phenylbutazone story. Phenylbutazone and oxyphenbutazone. They were found to be dangerous culprits to the bone marrow, knocking out the bone marrow. And so oxyphenylbutazone and phenylbutazone met the graveyard. Poor patient awareness was still prevalent at that point of time. Awareness of disease was very poor among medical practitioners as well as common public. Imagine, after I went only to the rheumatology department, I saw my first patient with ankylosing spondylitis. Nowadays, undergraduate students in their MBBS days are seeing patients with spondyloarthropathy. Most patients assume that ankylosing spondylitis is a disease only to the spine consulted orthopedic surgeon, and still it is there. They think it is a neurological problem and they go and consult a neurologist. Then what was born? The genetic association and risk of developing ankylosing spondylitis. HLA-B27, about which the doctor said. HLA-B27 was found. Initially, technology was primitive in terms of doing it by microlymphocytotoxicity method, which is followed by flow cytometry, and PCR, which is the darling of the laboratory technologists today. So they definitely established the association between HLA-B27 positivity and the risk of developing ankylosing spondylitis. Middle of 1980s, rheumatology departments were started and rheumatology practice was also started. Papers on ankylosing spondylitis started rolling over from all parts of the world, including India. And the first paper of ankylosing spondylitis was published by Professor Deodhar from PGI Chandigarh. A separate rheumatology department was established in Government General Hospital, Chennai. And a department of clinical immunology was established in All India Institute of Medical Sciences, Delhi. Awareness about ANG-SPON improved both in doctors and patients and community. AS patients started consulting rheumatologists, and subsequently clinics in rheumatology were established in medical colleges and corporate hospitals throughout the country. Rheumatology, which was given a stepmotherly treatment, was accepted as a super specialty then. Next slide, please. No, the previous slide. Then the orphan became a prince. If you take Buddha and Siddhartha, the prince Siddhartha became a beggar. But here it's just the opposite. The orphan rheumatology became a prince. And that is how rheumatology grew in 1980s and 90s. Next slide, please. So many papers have come from India. There are papers from All India Institute of Medical Sciences. Professor Malaviya and the group was published innumerable papers on ankylosing spondylitis and HLA association. Then from Dr. A.N. Chandrasekharan and their group in Madras Medical College. Then from SGPGI. So a lot of papers started rolling out from the various centers throughout the country. And we actually put our place in the map of rheumatology in the world. Next slide. C-reactive protein. For all of you, you will just say, okay, ankylosing spondylitis, high levels of CRP indicate very active disease. But what was I doing in 1984 to 1990? CRP was just emerging as a significant marker for disease activity in AS. But even CRP had to grow and evolve with respect to technology, because initially CRP was detected only by latex agglutination method. When I was a tutor in rheumatology department, it was reported as positive and negative, which ultimately meant nothing. You can't say a person's blood sugar is positive and negative. You have to quantify. Then quantification of CRP is established, and now laser nephelometric technique is used in quantifying and detection of CRP levels. Next slide. And monitoring of CRP levels is very useful in assessing the disease activity in ANG-SPON and the response to treatment. Radiographs, the only thing which was available, very economical, feasible, available in all hospitals throughout the country. It was the gold standard for assessment and quantification of structural spinal changes. But unfortunately, radiographic changes in a patient with ankylosing spondylitis with inflammatory low back pain take a minimum 2 to 4 years to develop. So what was happening? We were losing the window of opportunity to make a diagnosis of spondyloarthritis early in the disease and to result in early intervention. So radiographs had their own negative points. Next slide, please. Limitation with conventional radiographs. Now you take the elderly age group, there are degenerative changes which take place in the sacroiliac joint. I told you it's limited value in early disease diagnosis. It takes about 2 to 4 years to develop radiological changes in the spine of syndesmophytes and sacroiliac joint pathology. And radiographs do not have the ability to detect active inflammation at all. So early diagnosis may not be possible. You can't assess the disease activity, and ultimately it resulted in poor sensitivity and specificity. But still today, radiographs hold their own place and reputation in the various criteria in the diagnosis of ankylosing spondylitis. Next slide, please. Then after radiographs, what was born? The era of CT imaging. A very promising tool it was indeed to make a diagnosis of early spondyloarthritis, but it is fraught with its own disadvantages. Poor ability to detect soft tissue changes, usually normal until presence of structural damages. Finding and sclerosis, etc. were non-specific, not useful in monitoring disease activity, and it does not show active inflammation. Next slide, please. Then came MRA, the darling of the rheumatologist. The gold standard to make a diagnosis of spondyloarthritis is to get an MRA imaging done of the pelvis for the sacroiliac joint and the lumbar spine, which will pick up inflammation. And so MRA is a darling of the rheumatologist. It's a darling of the musculoskeletal radiologist. Next slide, please. Yeah, this is various MRA which shows active sacroiliitis, and then you people know better than I the fatty lesions which are seen in the lumbar spine, fat metaplasia. Next slide, please. So ultimately, to sum up with respect to MRA, it confirms the diagnosis, early detection, very early detection. It's useful to monitor disease activity, early detection of structural progression, monitor structural changes, and it predicts even treatment outcome. So the imaging of choice today throughout the world, even in India, is MRA of the lumbar spine and the pelvis or the sacroiliac joint. Next slide. So MRA became the gold standard to repeat, diagnose AS, assess disease activity, to assess radiological progression. But one thing which I saw as a rheumatologist as the time flew by, the MRA technology improved and better MRA machines with greater resolution have come into existence now. Initially, the problem with MRA was it was expensive and still continues to be expensive. It was only available at a few centers. Now throughout the country, most of all the metro cities and the other towns have an MRA facilities available, and they are also the price of the cost for doing an MRA also is reasonably coming down. So we are blessed to have MRA machines in the country, and I should thank science for getting an MRA machine into this country. Next slide, please. What are the pitfalls of MRA? There is no, well, like if I can say, there is imperfection even in perfection. So similarly, MRA has got its own pitfalls at all. It should be preceded by a proper clinical examination. My dear friends, we still have to follow Hutchinson's methods. Clinical history, clinical examination, then only investigations. Without seeing the patient, just don't look at the MRA and make a diagnosis. It assists in confirming a clinical suspicion of AS. There is a high degree of inter and intra-observer variability in interpretation. Today what we have is skilled, dedicated musculoskeletal radiologists who are the pundits in interpreting MRA of the spine and the lumbosacral spine and the pelvis. Next slide, please. Now we have the concept of identifying sacroiliitis as active, inactive, bone marrow edema, fat metaplasia, and enthesitis. But remember a point, still plain radiographs cannot be discarded into the dustbin. Use your discretion. That's very, very important. Next slide. Classification criteria. I would like to make a very important point here. We have so many criteria, the New York criteria, the modified New York criteria, the Rome criteria, which was useful to a diagnosis, and subsequently criteria are born every 2 years to 3 years. You want to be a researcher, you choose classification criteria. If you want to be a stupid clinical rheumatologist in me, needs diagnostic criteria. What is very, very important, ankylosing spondylitis is a diagnosis or the clinical diagnosis, the history and clinical examination substantiated by X-ray or MRA at that point of time. You can't keep the criteria at your consultation table and say these points are fulfilled, then only he's got ankylosing spondylitis. Next slide, please. By the time he fulfills the criteria, he'll be crippled. So you have so many things in 1995, 2001, so many things have come, 2003, 2004, 2005, 2006, 2011. All this, you pundits know better than I, so we'll just skip this slide. Next slide, please. Then you come down to the various timelines and the major events in the evolution of this axial SPA. It's a very complicated one, but it just says that it started in 1695, then in 1890, then in 1904, Then in 1940, then in 1963, the American Rheumatism Association separates AS from rheumatoid. Then 1973, discovery of HLA-B27. 1974, seronegative arthritis introduction. 1985, 1994, 2004, 2009, and it goes to 2016, 2017. I'll end up myself in the grave and still more criteria will come, and the previous criteria will meet me in my grave. Next slide, please. Treatment of ankylosing spondylitis. 1984, Ramakrishnan had nothing to offer, just to give non-steroidal anti-inflammatory drugs, just give conventional synthetic DMRTs like sulfasalazine and query-methotrexate. What happened? There was a wonderful thing which happened in 2002-2003. A wonderful infant was born, and this wonderful darling infant was christened as biologics, which has revolutionized treatment of AS. I'm not going to speak much about biologics because my subsequent speaker, various biologics have come into the market today. You have the TNFs and then you have the IL-17. Biologics became like COVID warriors in the war against ankylosing spondylitis and spondyloarthritis. Next slide, please. Now we have the ACR 2019 recommendations for the treatment of patients with ankylosing spondylitis. I need not speak about this slide because I'll be carrying coal to Newcastle. So most of you know the ACR guidelines. But today I would like to make a very important point. What Ramakrishnan could not do in 1984, and he could only offer his condolences, today has got wonderful biologics to give. Biologics are the drugs of choice in the axial disease of ankylosing spondylitis and spondyloarthritis. The sulfasalazine and methotrexate are not useful at all. And we have two good biologics, anti-TNF as well as IL-17 blockers. Next slide, please. Again, you have the ACR recommendation for the treatment of patients with stable Langspon. You can always go back. Next slide, please. Next slide. Has the journey of ankylosing spondylitis come to an end? This is my last slide. Today, scientists are burning the midnight oil on the etiopathogenesis of ankylosing spondylitis. There is a heterogeneity of ankylosing spondylitis in terms of disease presentation, disease progression, and response to treatment. Better imaging technologies than the available MRI will definitely come on the horizon. Specific biomarkers to assess disease activity are there in the pipeline. The connection between the gut and ankylosing spondylitis, the gut microbiome. Gut microbiome is involved in everything. Only thing it is not involved till now with respect to COVID. Maybe it's also involved. Gene polymorphism, cell sequencing molecules. But the last important statement I would like to tell you is, we have still not won the war at all. Therapeutic resistance to biologics continues to haunt the rheumatologist, and it's the rheumatologist's Achilles tendon. How to manage is still a matter of debate. So what I would like to tell you is, all that I said today will become history after 35 years when another rheumatologist speaks on the journey of ankylosing spondylitis, because science would have come to better perfection and we have better molecules. We will even be able to prevent ankylosing spondylitis with a vaccine. But unfortunately, I may not live to see that. Thank you very much.
Okay, thank you, sir, for a brilliant insight about the management of ankylosing spondylitis, how things have evolved over the last few years. Do we have any questions? Yes, I've seen the chat box. There are only people who have joined in and reached out. I don't see any questions. So let me ask you one question, sir. I think, what do you think are the challenges in the management of spondyloarthropathy, mainly in the urban settings and rural settings, because all the infrastructure is quite different. So any advices?
Yeah, that's a very important, relevant question, like what you had, the urban rheumatoid and the rural rheumatoid. If you take the urban areas, people are, well, a little more aware of the disease, and fortunately or unfortunately have the Google and the web to go inside and people read about spondyloarthritis. Patient awareness is greater there. They come and consult the rheumatologist specifically even earlier. And we are able to explain to them about biologics, but it is very, very difficult to convince an educated person to take a biologic, because unfortunately, thanks to the Google University, he is more informed, well informed than you and I. Very, very difficult situation. I find that most of my rheumatologic patients who come to me are better informed, and they come and ask me whether this is the first patient with ankylosing spondylitis I'm seeing, and how many patients with ankylosing spondylitis you have seen, what is your experience. In fact, once I told a fellow, have you come to interview me for a consultant port in the hospital, or have you come to take treatment? If you take the rural spondyloarthritis patients, innocent to the core, whatever you tell them is the gospel truth. They accept the treatment with biologics. They are ready to spend money. Here, unfortunately, they'll ask this discount, that discount, what will happen, etc. Can I go to America and take the treatment? And when you tell them when you go to America, it will cost you 100 times this price, then you will keep quiet. The rural with ankylosing spondylitis is better. I can treat a person from a village better. Sorry to tell you that. This is what I experienced even in a big corporate hospital, to be very frank. Like your own Bengali patients, when they come to Chennai, they listen to me. I do not know why they come in to listen to me. Probably because they think I'm Ramakrishna Paramahamsa, which I'm definitely not. Definitely not at all. Then the other important fact is, since the patient awareness is not there about ankylosing spondylitis, they go to all alternative systems of medicine and come a little late. That's the only thing which is very, very important. What I need is, the need of the day is to do patient education regarding biologics, so that I do accept the cost factor involved in that, but we have to speak the truth. I always believe in one philosophy. Truth may be bitter, but it is better. And the best to tell the patient that the disease is not curable, it is only controllable. That is what is there. Then the second most important thing, I'll take 2 minutes of my own self, because a lot of people, when they come with inflammatory low back pain, the diagnosis is only spondyloarthritis, and we get away with that. I would like to show, if you could give me 2 minutes time, I can just show you some important photographs of patients in whom I have missed the diagnosis. Because my important is 35 years of experience, I have made wrong diagnosis more than the correct diagnosis. They say, no, unless you kill a person, you will never become a doctor. Sorry to say, I have not killed anybody. Rheumatologist patients, you can never kill, They kill you with pain on frequent visits. Can I have the slides, please? I'll just go in 2 minutes, I'll finish the slides.
Yes, please carry on, sir.
Can I have the slides presentation continued, please?
And I think if you have any experience like where you learned the most, have been wrongly diagnosed.
Next slide.
Oh.
Next slide, please. This is very important. See, surgical intervention. This man was such a disciplined husband. He never saw his wife face to face, like what we do at home. And see, after surgery, he is able to see forward. Surgery. Next slide, please. Quadruple joint replacement in a patient with ankylosing spondylitis in Bangladesh, brought crippled to the hospital and ultimately walked back home. This is what is called surgical intervention in ankylosing. Next slide, please. Osteitis condensans ilii, seen most in postpartum women, wrongly diagnosed as ankylosing spondylitis because of the sclerosis. The sclerosis in osteitis condensans ilii is on the iliac side of the sacroiliac joint. That's very important. Next slide, please. Ochronosis, coming with low back pain. Please look in the X-ray for intervertebral disc calcification. Next slide, please. Infectious sacroiliitis. Unilateral low back pain, sacroiliac joint area with constitutional symptoms with a query infective focused elsewhere. Think of infectious sacroiliitis, early MRI, then you can do a CT guided biopsy, and ultimately you can give them with antibiotics, or they may require surgical intervention. Next slide. TB is the commonest cause for infectious sacroiliitis in this country. I want to share a very, very important point here. When a patient with ankylosing spondylitis is unresponsive to your biologic, you may think of biologics failure and switch on to another. Before that, please kindly exclude malignancy of the spine, especially in any age, maybe 40, 45. I have seen people with secondaries in the spine, with people with lymphoma also. This is very, very important. So, a resistant ankylosing spondylitis does not mean you are not treating properly. It means that you are not diagnosing properly. Next slide, please. Next slide. Fracture in patients with ankylosing spondylitis is quite common, like as what you see over here. Trivial, because they are osteoporotic spines, a trivial fall they can break the spine. Next slide, please. Next slide. Spondylodiscitis, constitutional symptoms, MR epixitum. I have seen patients with ankylosing spondylitis with associated tuberculosis of the spine. That's a very, very important condition. I do accept biologics cause extraskeletal tuberculosis, but I have seen patients even skeletal tuberculosis are put on biologics also. So please think of tuberculosis and get an MRA done. Next slide. This all of you know, diffuse idiopathic skeletal hyperostosis, exuberant osteophytes you see. I tell you, so many patients of these have been diagnosed as ankylosing spondylitis. They have a stiff spine. See, their sacroiliac joint will be normal, and this is what is something which taught me rheumatology in dental hospital. Fluorosis. Fluorosis is still endemic in India. It is endemic in Rajasthan, Andhra Pradesh, even I think in areas near Guwahati and all. So one important fact, typical X-rays of fluorosis which you see, just remember these are all what we call the mimics of spondyloarthritis. But having seen it in practice, I should not miss it. Last slide, please. Brucellosis. As a rheumatology tutor in 1984 to 1990, I saw a lot of patients with infectious spondyloarthritis secondary to brucellosis, not present now. Next slide, please. And this is a very important diagnosis which I missed. Last slide, I will not trouble anybody more. My patient came to me with severe low back pain. I did a clinical examination of him. He could not even move his spine forward and backward. I immediately said, this is ankylosing spondylitis. Go and get an X-ray done. He got the X-ray done and came back next day evening for review. I saw the X-ray, normal pelvis, disproportionate to his restricted spinal movement. I examined him again and his spinal movements are normal. You know what I did? I had missed that he was wearing a lumbar corset the previous day. A busy outpatient clinic. We are all intellectuals, always associated with the technology and gadgets and investigations. Taking history has become history. Why no clinical examination is a mystery. Only laboratory investigations. Is it to make a purse full? No. So clinical examination, I missed this diagnosis. I should openly tell. I apologize to the patient and also paid the money for the X-ray which he had paid. Thank you. No more slides. Thank you. Bye.
Thank you very much, sir. I think we have a question now from Dr. Vijay K. Rao. Is it true that, I think this is probably a question for us rather than yourself. So is it true that I'm seeing more SPA prevalence in West Bengal population? Any comment on that?
No. It's nothing like that. It's also prevalent in Chennai. The only problem in Chennai, we see more patients with spondyloarthritis from Bengal. That's what. Not that anyway. We see a lot of patients with spondyloarthritis in Tamil Nadu and the southern parts of the country. It is prevalent everywhere. It is prevalent everywhere. Because, you know, you see one important point is, I find that the patients in Bengal, they are more sensitive to health and immediately seek medical attention. In the south, Tamil Nadu, especially the villages, they are not bothered about low back pain. They say low back pain and keep walking, no? But the sensitivity of yourself to fall ill, see, imagine how many people will see you with gas. It is like that. And the important cause for gas is low back pain is gas inside the spine. It's very important. So, no, it's nothing. It is seen everywhere, to be frank, very prevalent. In fact, I've written papers also on spondyloarthritis, ankylosing spondylitis from Chennai, from South India.
But you just one comment from me. I think because Vijay is also trained in UK. I think when we are in UK, we were told that HLA-B positivity and ankspondy is very less in India. But my ideas has completely changed. We have seen so many HLA positive patients in India and Bengal as well. Probably we haven't got the right kind of study to just reflect that.
Yeah, Dr. Malavia and Dr. N.V.K. Mehra have done a lot of research between HLA-B27. The prevalence may be a little lesser. But one important point is,
1 per 1,000.
1990, when the HLA-B27 was discovered, everybody with low back pain had an HLA-B27. And he became a neurotic, ankylosing spondylitis neurotic. He'll walk around all the clinics and ask, when I will develop ankylosing spondylitis. Because not all people with HLA-B27 develop ankylosing spondylitis. HLA-B27 investigation, I think it is better it is done by the rheumatologist and not to be done by just an ordinary general practitioner and get the patient confused, because they take that result as an Aadhaar card and go around the country saying that I got ankylosing spondylitis. B27 positivity is not synonymous with the diagnosis of ankylosing spondylitis.
That's right. That's right. Thank you, sir. I think we don't. I can't see any more questions. Yeah.
Dr. Sharma wants to say something.
Sorry.
Dr. Pradeep Sharma wants to say something. I think.
Yeah, sir.
Oh,
Please.
oh
Sir,
God, Dr. Pradeep Sharma. Pradeep Sharma is my master. Good evening, master. He's a very brilliant rheumatologist. I always get frightened. This fellow comes in all the webinars and really puts me at. My heart rate is now 120 with a pulse oximetry of 80. I got admitted in Apollo Hospital as query COVID. Yeah, Pradeep.
good evening,
So
sir.
now good evening, good evening. You are pulling my leg, so now I will pull your leg.
I'm not, I'm fragile, man.
So it was a very nice presentation. So just one thing, you have highlighted the MRI actually, very, but I want to just, this is where we are using actually MRI. Most of the time, most of our patients comes late. Actually, clinically you can make a diagnosis. Most of the time we are diagnosing radiologically. In those patients, actually we don't do MRI. And I have seen that many patients who have already developed bamboo spine, already developed kyphosis, even they also comes with an MRI if they go to a neurologist and orthopedic surgeon. So that's why the role of MRI in ankylosing spondylitis. Probably we are using it only for diagnosis when there is no radiological evidence. When X-ray shows nothing, then only we are doing an MRI of the sacroiliac joints or the spine. Apart from that, are we using this MRI for seeing the progressions or seeing the response to treatment also?
Yeah, very good question, my master. Number one, routinely doing MRI in all patients with back pain is not needed. Number two, when they have clinical signs of ankylosing spondylitis, I think an X-ray is enough. That's why I said radiographs are not to be discarded into the dustbin. If a patient with ankylosing spondylitis, inflammatory low back pain is in the earlier stages, and then he's found to be HLA-B27, then if the X-ray is normal, then I go for an MRI. MRI initial diagnosis and disease activity is there. But unfortunately, due to cost restraints, if at all we want to repeat MRI to assess the response to biologics, we can do it once a year. But one important fact is MRI is also misused a lot. And like Pradeep, like so many sacroiliac changes are seen in people, in athletes, postpartum women, runners, etc. And the wrong interpretation of MRI. So MRI is a very useful diagnostics tool, but it has to be used with great caution, taking into consideration the clinical presentation of the patient. I accept, Pradeep. That's why I call you my master.
Another thing, sir, this evolution of HLA-B27 as a diagnostic. Actually, when we were a student, we were doing DM. At that time, we were taught that HLA-B27 should not be used for diagnosis. Actually, we used to laugh at the orthopedic surgeons when they use HLA-B27 routinely. But nowadays, actually, they are laughing at us because we are giving so much emphasis on HLA-B27 for diagnosing, especially this non-radiological spot.
Yeah, right, Pradeep. Now, HLA-B27 is among the criteria for patients with ankylosing spondylitis when people cannot get an MRI done, especially with inflammatory back pain and they have extra articular features. I do accept it. For once, orthopedic surgeons were very good astrologers predicting the truth in the future, and we were blind to the truth. I do accept HLA-B27 can be used. Again, it has to be used with great caution because lot of normal people, like a master health checkup, go and get the HLA-B27. Some people go and do HLA-B27 in 55 years and 60 years, and poor fellow, till he goes into the grave, he goes with the diagnostic label of ankylosing spondylitis. So what I am telling you, Pradeep, one important point, investigations should always be tailored to the need of the patient to make a diagnosis. Ultimately, it comes down to only a clinical diagnosis. That's very, very important, Pradeep. I don't know if you have anything, please tell me, I'm ready to take it. Because I'm still in the learning curve and to learn a lot.
Thank you, sir. Thank you so much, sir.
Thank you, Pradeep. Thank you very much.
Thank you, sir.
Dr. Sharma, for the nice questions. We'll probably move ahead for the next session.
Sure.
I'd like to Dr. Abhra Chandra Chowdhury for the next. Sorry.
Dr. P.K. Chowdhury wanted to ask something. So there is a
Uh,
question in the chat box of Dr.
I think
P.K.
this is
Chowdhury.
actually because we'll probably discuss at the end. So after the treatment
Oh,
is. Sure.
okay.
So I'll invite Dr. Chandra for the next talk, which is a recent updates on the use of IL-17 blockers in and SPON. So over to you, Abhra.
Thank you, Parthajita. Can you see my slides?
Yeah, I think you're audible.
No, I mean, are the slides visible? Because there is some problem with my internet connection.
I
Are
think
the slides visible?
we can see your slides. Yeah.
Okay, okay,
Yes,
okay.
yes,
So,
visible.
yeah. So, thank you all. After that nice lecture by Sir, I hope I'm able to do justice to this topic. So, I'll speak on the what is new on the IL-17 blockers in ankylosing spondylitis in the last 3-4 years. So I've divided my talk into basic science updates and clinical science updates. So as there are some postgraduate students in this group, in the audience also, so I'll just briefly tell about what is IL-23 and IL-17 axis. So the naive T cells, which under the action of cytokines like IL-6 and IL-23, they get transformed into Th17 cells, and these Th17 cells can produce cytokines like IL-17. There are other cells, you must have heard of Th1 cells which can produce TNF. So there are other host of other cells also, the innate cells which can also produce the cytokines IL-17 and IL-22. So this is what we call as IL-17 and IL-23 axis. The IL-23 production by the dendritic cells or macrophages, and the IL-17 is produced by Th17 cells. So if we see the history of IL-17, IL-17 is a comparatively newer cytokine. It was described for the first time in 1993, and in 2003 only IL-23 was identified as a driver of IL-17 producing T cells. And only in 2010, the first trial of anti-IL-17 blocker in psoriasis was started, and 2014, the first global approval of anti-IL-17 therapy for the treatment of psoriasis and psoriatic arthritis was done. And if you see in ankylosing spondylitis in 2013, the first phase 2 trial of IL-17 blocker in ANGSPON came out. 2015, we had the measure 1 and 2 trial. 2016 was the FDA approval for IL-17 blockade secukinumab for ankylosing spondylitis. In 2017, we had the measure 3 trial. 2019, we had the prevent trial. So IL-17 is a comparatively newer molecule as compared to anti-TNF. So, what is the evidence that this axis is involved in spondyloarthritis, this IL-23, IL-17 axis? So, genetic studies, namely the genome association studies, have shown that IL-23 receptor polymorphism is associated with susceptibility to ankylosing spondylitis, psoriasis, Crohn's disease. Also, the intracellular misfolding of HLA-B27 molecule has been reported to stimulate the IL-23, IL-17 pathway in vitro studies. Mice experiments of animal models of spondyloarthritis have shown IL-17 production in an IL-23 dependent manner. Also, in patients with ankylosing spondylitis, psoriasis, there was increased level of IL-17 and IL-23 in the peripheral blood and synovial fluid of patients, as well as the skin of the psoriasis patients, as well as the gut in Crohn's disease patients shows increased levels of these cytokines. The facet joints of ankylosing spondylitis have shown positivity for IL-17 and IL-23 positive cells, as well as the spinal subchondral bone marrow also have shown positivity for these cells. So this is all about the preclinical evidence. But what has the clinical trial results of IL-23, IL-17 axis blockade shown? So IL-17 blockade have shown very good efficacy in ankylosing spondylitis, in psoriasis, and in psoriatic arthritis. But there was no response in case of patients with ankylosing spondylitis who had associated inflammatory bowel disease, or if they were being used de novo in patients with Crohn's disease, they had worsening of inflammatory bowel disease. So IL-23 blockers, on the other hand, have shown very good response in psoriasis, moderate response in psoriatic arthritis, inflammatory bowel disease, and absolutely no response in ankylosing spondylitis. So if we think about the axis again, IL-23 is a cytokine which is upstream to IL-17. So going by this, if the IL-17 is important in all these diseases, so IL-23 blockage should also have been effective. So there is a discrepancy between what the preclinical study shows and what the clinical trial results show. So this shows that there is an uncoupling between IL-17 and IL-23. Now the problem with ankylosing spondylitis is inaccessibility of the tissues in the spine. The best way to find out what is happening in the spine is to biopsy the tissues and study the immunologic pathways, which we can do very easily in rheumatoid arthritis. But the spinous tissue is not very much accessible. So this increases our difficulties because the mice experiments and the other preclinical studies does not always corroborate with the clinical results. So we have some few papers published in the past couple of years which have given us more insight into why this uncoupling occurs. So the first experiment, which was published in 2012 by Dr. Jonathan Sherlock, which gave us insight into IL-23 and IL-17 axis. This was a landmark paper. So it showed that in this mice model, they showed for the first time that there was a group of cells which is not the typical CD4 or CD8 cells. These were CD4, CD8 negative, but this was CD3 positive. And this CD3 positive cells produce this IL-23 was essential in the enthesitis, and these cells could produce IL-17. So this first time the enthesial resident T cells were described, which were not classic T cells, but these were CD double negative T cells. So subsequent experiments in 2016 have shown that these cells were nothing but what we call as gamma delta T cells, and they produce IL-17 in a IL-23 dependent manner. And these cells were present in the enthesis, in the aortic valve, and in the ciliary body in mice. So till now, all of these were mice experiments. So the most significant results in this regard have been given by Dr. Dennis McGonigal and his group from Leeds, UK. So they have produced a couple of papers in the last few years which have given us more insight into the pathology of ankylosing spondylitis. So what they have done is they have taken patients, not exactly patients of ankylosing spondylitis, but patients of other spinal diseases like say scoliosis who were undergoing surgery for other problems. So they have taken the surgical samples. What samples have they taken is the enthesial soft tissue present in the interspinous ligament as well as the perienthesial bone from the spinous process. They have digested these cells and they have tried to identify the cells by flow cytometry. And they have done also other stimulation experiment to see what other cytokines produced by this in this enthesis. So what you can see that apart from the usual routine B cells and T cells which are also present in the periphery, this is the black one is the peripheral blood, and the other two are the cells in the enthesial soft tissue and perienthesial bone. So another group of cells was present in the enthesial soft tissue and perienthesial bone which was not present in the peripheral blood in equal amounts. So later on, this was shown to be a group of cells which is called as innate lymphoid cells. So innate lymphoid cells had originally been described in the gut, and it was hypothesized that these cells may travel to other places like the joints and produce inflammation. They have been previously isolated from the joints and from the synovial fluid of patients with ankylosing spondylitis. But it is for the first time that they have been shown in human enthesis, and this is not a patients with ankylosing spondylitis. This is patients without ankylosing spondylitis who have this group 3 innate lymphoid cells, and they have shown that this group 3 innate lymphoid cells also produces IL-17 in an IL-23 dependent manner. In the same kind of experiments in which people have taken the enthesial soft tissue and perienthesial bone, they've also shown the presence of enthesial resident T cells. Remember, the previous resident T cells were shown in mice. So this was the first description of enthesial resident gamma delta T cells in man. And two subsets of gamma delta T cells have been identified, the V delta 1 and V delta 2. And the stimulation experiments, when they have in vitro settings, they have stimulated with IL-23, there was hardly any IL-17 production in the V delta 1 subset, whereas when stimulated with IL-23, V delta 2 subset of gamma delta T cell produces IL-17. So thus there exist two definite subsets of V delta gamma delta T cells. One produces IL-17 in an IL-23 independent manner, and one produces IL-17 in a IL-23 dependent manner. So it is an other thing that is to be noted, that this V delta cells is more in peripheral blood, whereas the V delta 1 cells is more in the spinous tissue. So this is also in the normal human individuals. This is not in patients with ankylosing spondylitis, but it has been shown that there is IL-17 production in an IL-23 independent manner. So this can somehow explain the results that IL-23 blockade is ineffective in spinal disease, whereas IL-17 blockade is effective because IL-17 is being produced in an IL-23 independent manner. So the same group has also shown the presence of CD4 and CD8 T cells, and they've shown that the enthesis-derived CD4 T cells secrete both tumor necrosis factor and anti-IL-7 and IL-17, whereas CD8 cells produce only TNF, and this was also without the use of other cytokines like IL-23. Again, IL-17 production without the effect of IL-23. So right now, what are the cellular sources of IL-17 that we know of? So among the adaptive immune cells, the Th17 cells and CD8 cells, and there is a very small group of cells which has tissue resident memory T cells. And among the innate cells are group 3 innate lymphoid cells, the gamma delta T cells, and these two population of the cells also have been newly described invariant natural killer T cells and mucosa associated invariant T cells. So there are a lot of innate cells which are involved in the production of IL-17, and these can produce IL-17 in an IL-23 independent manner. So now again the question rises that this explains why IL-23 blockade is ineffective but IL-17 blockade is effective in spinal disease. Now what about inflammatory bowel disease? So inflammatory bowel disease, what is the role of IL-17 in the gut? So IL-17 maintains the integrity of the epithelial mucosa in the gut. So it has protective action. It protects against pathogens like extracellular bacteria and fungi. So in the gut, as opposed to the joint, IL-17 has protective action, and that is why blockade of IL-17 in the gut has shown exactly opposite effects. That is, in some cases it can lead to worsening of inflammatory bowel disease. So this is a paper published recently. So in this paper, what people have done is they have taken patients treated with IL-17 blockade as well as TNF, anti-TNF, and they have collected the fecal samples and they have analyzed the fecal microbiota. So patients treated with tumor necrosis factor did not have much alteration in microbiota, but patients treated with IL-17 had decreased Clostridium species and increased Candida species. And previously it has been shown that decreased Clostridia and increased Candida in the gut can lead to triggering up of inflammatory bowel disease. What this group has also done, they have taken in patients who have developed Crohn's disease after treatment with IL-17, they have taken ileal biopsies, and they have shown that there is expansion of a different group of cells which produces IL-25 and IL-17E. So which IL-17 which we usually talk of is IL-17A, but this is a group of cells which produces IL-17E and IL-25. So this gives us further insight as to why the IL-17 blockade may not act in the gut. But then again, the real life experience is different. So this is a systemic review and meta-analysis which has taken almost 70,000 patients who were treated with IL-17 blockade, and there were only 12 new cases of IBD. So there was no difference in the risk of developing of IBD with anti-IL-17 agents compared to placebo. So the question arises that should we screen patients who are at risk of developing IBD before starting IL-30 pocket. So the risk is very less. But if we want to do so, fecal calprotectin may be a useful marker. So if the fecal calprotectin is less than 250, the risk of IBD is very less. And if fecal calprotectin is more than 250, then we may have to do further investigations, ask for a history, or maybe refer to gastroenterologist. So this is not what has been proposed in the guidelines. This is something that has been proposed in one of the papers, and it may require further trials to validate whether this is actually useful or not. So now coming to the clinical updates. So we have 4 studies of secukinumab in ankylosing spondylitis, measure 1 to 4. So measure 1 study, what they did was they've taken given IV secukinumab at 0, 2 and 4 weeks, followed by from 8 weeks onwards 150 mg subcutaneous secukinumab in one arm, 75 mg subcutaneous secukinumab in the other arm, and placebo in arm. And so the initial results, primary endpoint was SS20 response at 16 weeks. We got the extension studies till 2 years, and now we have the 4 and 5-year-old data. So what does the 4-year results from measure 1 study show? So there are 2 things which needs to be analyzed: whether it is effective in inflammation and whether it prevents structural progression. So as far as inflammation is concerned, the SS20 response even at 4 years was very good. Almost 80% patients had SS20 response, and 60% patients had SS40 response. And if we see the structural progression, so we measure structural progression by the change in MSAS. So the structural progression, which was initially measured up to 2 years, was very less, and structural progression from baseline up till up to the 4-year also shown that there was hardly any structural progression. Now, maybe in this cohort of patients in the measure 1 study, there was very less structural progression. So we definitely know that secukinumab inhibits the structural progression. Now, is it better than anti-TNF? To say this, we need head-to-head trials. One of the trials is now ongoing, but without head-to-head trial, it is definitely difficult to say whether it is better than anti-TNF. But right now, we know that it inhibits the structural progression. So we also have the 5-year results from the phase 3 measure 1 study, and like as you have seen in the 4-year result, the SS20 response was quite good. 77.6% patients had good SS20 response, as well as 64% patients had SS40 response. And this was in anti-TNF naive patients. Almost 78% patients had SS20 response even at 5 years. So that's a very good thing to know. This year we also had the 5-year efficacy data of the measure 2 trial. Measure 2 trial used subcutaneous secukinumab in place of IV secukinumab from the beginning. So loading dose of 0, 1, 2, 3, 4 weeks was given, followed by every weekly dose, followed by every monthly dose was given. And in this cohort also, 67% patients had an SS20 response at 5 years, as well as 50% patients had SS40 response at 5 years time. Now in this cohort, 60% patients were anti-TNF naive, 39% patients who had past exposure to anti-TNF, and 68% patients completed 5-year treatment, including 78% patient in the 150 mg group. So that's also a very good data. The retention rate of secukinumab was very good. So coming to the measure 3 trial. So measure 3 trial has given initially 3 doses of IV secukinumab at 0, 2 and 4 weeks, followed by 2 doses of subcutaneous secukinumab at every monthly interval. 1 dose was 300 mg and 1 dose was 150 mg. Remember, in the measure 1 trial, we have used 150 mg and 75 mg. So in this trial, it was 300 mg and 150 mg. So the primary endpoint, which was published earlier, was at 16 weeks. SS20 response at 16 weeks was quite good. 60% in the 300 mg and 58% in the 150 mg. So now, this year again, we had the 3-year results from this measure 3 study. So it has shown that the SRS-20 response was equally good in the 300 and 150 mg group. But if we take harder endpoints like the SRS-40, SRS partial response, they were actually higher in the 300 mg group, and particularly in patients who had TNF inadequate responder groups. In that, the 300 mg group was better. So till now, the dose that is approved for ankylosing spondylitis is only 150 mg, but 300 mg may be beneficial in a subgroup of patients, especially those who have received anti-TNF previously. So Measure 4 study was published in 2018. So this study tried to see whether the 150 mg loading dose versus if we give without 150 mg loading dose, that is monthly dose from beginning, if there is a difference between the two. So there was no difference between the two doses, but what was really concerning in this study was that there was very high placebo response, which was almost equal to the response of the patients receiving secukinumab. There was no significant difference. So this is so the results will require a lot of further interpretation and further long-term follow-up. So the papers that we have now is the pooled analysis, the post-hoc analysis of this measure 1 to 4 data. So when we use the secukinumab, one of the thing is whether it is active in inflammation, it is effective for inflammation. So measure 1 to 4 study by the SRS-20 response has answered that. Second thing is whether it acts in radiographic progression. So the extension studies of measure 1 has answered that. So the other concerns are the extra-articular manifestations. So is there any increased risk of uveitis, increased risk of inflammatory bowel disease, and what is the risk of infection, what is the risk of immunogenicity, what about other side effects. So the pooled data analysis from all these studies have tried to answer this. So this was again a study pooled analysis published this year. What was the risk of uveitis? So in all the phase 3 studies, 794 patients had taken part, and the number of uveitis cases was very less, only 3.3% cases. And so new onset cases was 1.5% and 1.8% had uveitis flares. In these patients, 1.8% had pre-existing uveitis. So how does this data compare with anti-TNF? So the exposure associated incidence rate, that is the combined new onset and flares reported in patients with anti-TNF, has been reported. Remember, this includes etanercept as well as adalimumab, golimumab, and all the anti-TNFs combined was found to be 2.6 to 3.5% per 100 patient years. But in the pooled analysis of the phase 3 trials with secukinumab, the EAIR of uveitis was only 1.4 per 100 patient years, which is reassuring, given that 17% in patients in this cohort had reported a prior history of uveitis. So what about immunogenicity? So secukinumab was associated with a very low, that is less than 1% risk of immunogenicity. We know that immunogenicity is a big concern as far as anti-TNF is concerned, but with secukinumab, the risk of immunogenicity was very low. So what about long-term side effects? So again, 794 patients in ANGSPOND as well as patients have been pulled from other trials in psoriasis as well as psoriatic arthritis. So the most frequent adverse effects was upper respiratory tract infection. There was mild risk of candida infection, and what is important for our country is the risk of tuberculosis. So there were no cases of tuberculosis reactivation which was noted, and the incidence of anti-drug antibodies was also low. So what is the effect of HLA-B27 status on patients treated with secukinumab? Why this is important? Because in negative HLA-B27 status is known to be a predictor of worse response to anti-TNF. So in case of secukinumab, this was not known. So the pooled data shows that HLA-B27 patients, positive patients receiving any dose of secukinumab, were significantly more likely to achieve SRS response, SRS-20, SRS-40, BASDAI-50, and ASDA-CRP response versus those receiving placebo. However, HLA-B27 negative patients receiving secukinumab 300 mg were significantly more likely to achieve SRS-40, SRS partial response, and BASDAI-50, that is the higher target. So as far as SAS 20 response is concerned, 150 mg and 300 mg, there is hardly any difference between the two groups. But when SAS 40 response is concerned, probably 300 mg does better than the 150 mg dose. So if we take patient's global assessment and the total spinal pain, so patient's global assessment, there was no difference between the 300 mg and 150 mg dose. But in case of the spinal pain, HLA-B27 positive patients experience significant reduction in the total spinal or back pain versus placebo. So again, 300 mg dose may be more effective in the HLA-B27 negative patients. So what about any extra benefit when we use secukinumab in respect to non-steroidal anti-inflammatory drugs? So the pooled data has again shown that there is a sparing effect of NSAIDs in patients who have been treated with secukinumab. So how do we measure this? There is something called as the SAS NSAID score in patients, which measures the cumulative NSAID exposure, and you can see the secukinumab produced sustained improvement in this NSAID score in the AS patient, and was associated with NSAID sparing effect in ankylosing spondylitis patient, especially in the group which had a very high NSAID exposure. The mean NSAID score, SAS NSAID score, decreased with time in both the dose groups, but greater improvements were observed in the high NSAID users and with longer treatment exposure. So this is again extra advantage of using secukinumab. So when we use secukinumab, one question that always raised my mind, that is it effective in peripheral arthritis? So we know that it was effective in the spine, but there was no separate data whether secukinumab is effective in peripheral arthritis, and there had been concerns. So this results, which was published in EULAR this time. So the symptoms of peripheral arthritis were also significantly improved in patients with ankylosing spondylitis which were treated with secukinumab. So if we see the lower endpoints like 20% improvement in the number of swollen or the tender joint, there was no difference between the 300 mg group or the 150 mg group. But if we see the harder endpoints like the 70% response or the 100% response, there was some difference between the 300 mg dose and the 150 mg dose. So secukinumab led to significant improvement in the symptoms of peripheral arthritis, and more improvement was there in the swollen joints rather than in the tender joints. So joint swelling improved better than joint tenderness. So what about the risk of inflammatory bowel disease? So again, in these patients, 794 patients treated with ACE, there were only 4 cases of ulcerative colitis, 8 cases of Crohn's disease, and 1 cases of non-defined inflammatory bowel disease, 9 or new onset cases. So the incidence rate was very less, and it did not increase over time with secukinumab treatment. So the first ongoing head-to-head trial of secukinumab versus adalimumab biosimilar to compare the radiographic progression is ongoing. This is called as the SURPASS trial. It is a phase 3 study. So 858 biologic naive patients with angstpon with elevated CRP and at least one syndesmophyte in the cervical or lumbar region at baseline were randomized to receive secukinumab 300 mg or 150 mg or adalimumab 40 mg. So the spinal x-rays, this is a 2-year study. Spinal x-rays will be obtained at baseline at week 52 and 104 weeks. And MRI of the SI joint and spine at 16 weeks, 52 and 104 weeks. So the trial results is still awaited. This will be very interesting data to know. Cost effectiveness. Numerous studies have shown that secukinumab was the most cost effective treatment option for biologic naive patients as compared to other biologics. So summarizing, the secukinumab is effective in axial spondyloarthritis in spine as well as peripheral joints and enthesitis. There was no significant radiographic progression till 5 years, but need head-to-head trials. It can decrease the requirement of NSAIDs. There was no significant flare-up of uveitis or IBD, but again need to screen patients at risk of IBD. So 300 mg dose may be more effective in resistance cases like anti-TNF treated cases or HLA-B27 negative cases. It is completely safe in long term with respect to infections, especially tuberculosis, and the risk of immunogenicity is very less. So thank you very much.
Yeah, thank you, Abhra, for the very detailed talk about the pathogenesis of angstpon linked to IL-17. We probably wait for the results for surplus study to tell us where adalimumab or IL-17 blockers, which is more efficacious.
Yeah.
So we are basically there are a few questions now. I think we haven't covered JAK inhibitors, but I think there's a question from Dr. Pranav Chowdhury that what will be your opinion on treatment with JAK inhibitors, though it's out of the box?
There has been certain initial reports that JAK inhibitors are effective, but then, I mean, in this presentation, I have not looked at that, but there are certain initial results that JAK inhibitors are effective.
They are showing quite good results, but probably
I mean, as far as angstpon and IBD both.
Yeah, tofacitinib has got very good evidence now.
Yeah.
Again, there's a question from Dr. Vijay K. Rao for Abhra. What's the time of onset of action in axial SPA with IL-17 blockers in real life experience?
In real life experience, actually, it is some patients which I've used, it is effective by 4 weeks time. But again, patient to patient vary. I mean, some patients have a very good early onset of action by 4 weeks, but some patients need to continue for 3 months. So patients to patient vary, and maybe it will be good to know the predictors as to, I mean, why is this variance?
Again, there's one more question for Abhra from Vijay K. Rao. I feel anti-IL-6 clinically meaningful dose for active pure axial disease in real life is probably 300 milligrams and not 150. Any comments? I think we probably have to wait for the results or the results to come back.
There are no results, but I heard that there was recent FDA approval for the 300 mg dose for the ankylosing spondylitis also. And in real life also, I feel that in some of the cases, not in all cases, especially those with peripheral arthritis, 300 mg dose may be better. And those with who have already anti-TNF failure, in those cases, 300 mg dose may be better.
And I think even for psoriatic arthritis, I think the dermatologists, they usually use 300 rather than 150.
Yeah.
So patient with psoriatic arthritis and SPA, probably 300 would be a better option.
Yeah. But again, 300 mg dose is very expensive, so that is again one of the concerns for us in long time.
They have to buy 2 injections rather than 1 injection. There is no combined injection so far at the moment. So another question for regarding immunogenicity leading to secondary ineffectiveness, which probably has been already answered now in the presentation.
Hello.
There is a one more.
Hello.
Hello.
Yeah, I'm Dr. Pranav.
It's carry on, sir. You want to ask anything?
Yeah, I just wanted to ask Dr. Abhra regarding a patient of mine, and he has been a patient of angstpon with hip involvement, hip joint involvement, bilateral, and that patient was on secukinumab for quite some time, last to 1 year. But in between, he has stopped taking citalopram also because he was given earlier when he was not given the biologic, that is secukinumab. He was doing very well in terms of CRP, low CRP and normal CRP and other clinical problems. But later on, of late, he has been replaced. His hip joint has been replaced, have to be replaced because of severe joint involvement, and at the same time, the second hip joint is also getting involved. So now, what is the option actually to treat the patient further. He definitely his second hip joint is also to be replaced. I think so. What to do, like management wise?
Sir, I think, like hip joint involvement is a chronic process. So most likely he would have already have some involvement of the hip joint even before secukinumab was started.
Maybe,
Because
yeah.
clinically a hip joint involvement would take, at least 5 to 10 years for it to be replaced. So most
Exactly.
likely the other hip joint would already have been involved by the time we had started secukinumab.
Yeah.
So
Is there any role like the secukinumab increased dose of by secukinumab? Say he was on 150 milligram. Now, if I just increase the dose, will there be anything outcome changes like that? Any changes in outcome or the hip arthritis or peripheral joint involvement, anything like that? No.
So we can try it out. In order to, because if we can save the other hip from replacement as long as we can still try it out.
Exactly. Huh.
There's no harm in trying out the increased dose because the other option is to wait for the joint to get totally damaged and replace it. So there is no
Right.
harm in trying out the 300 mg dose if you can afford it.
Because he's a young guy, around 35 years old, and so he is a little bit in a very precarious situation.
No,
So,
I think we need to know what exactly is the cause of the pain. If it's a damage, it's more of a joint damage like the osteoarthritis, then
yeah,
probably just using the dome is not going to help much. But if
Yeah.
yeah.
MRI scan or any imaging evidence of active synovitis or active inflammation,
Hmm.
then probably increasing the dose might help to reduce the inflammation and stop the progression of the disease.
One more thing, like because of this pandemic situation, he's not able to come to my chamber, not getting examined by me, and just on video consultation, I'm able to give him some, some
So
treatment.
the thing is, I sometimes doubt that would examine add to anything because even if it's active synovitis or a damage, the hip joint movements will be restricted. So would the examination actually add to anything? I've been seeing all patients by teleconsultations only now. So maybe patients can do MRI in their own place and can send the report. So that would be,
Yeah, that is the problem also
because
because he's
clinical
in a very
examination would hardly add to anything in this case. The hip joint movement would anyway be restricted.
exactly. The problem is
Pain,
there
pain
only.
could
Yeah,
be a limiting factor as well.
yeah. Thank you
Okay.
very much,
Dr.
Abhra.
P.K.
Thank you, sir.
Sharma wants to say something.
So there's one more question from Vijay Kira for Obro. What's the efficacy of isolated HLA-B27 uveitis? I'm
I
not
don't
whether
think it
is it
has been studied. Isolated HLA-B27, the secukinumab in HLA-B27 uveitis, positive uveitis. Most of the results are for the joint disease, the spinal disease. Isolated uveitis is not. There is no data.
right. And there's one more question for the Novartis team. So
Dr.
why
P.K.
don't
Sharma.
we, oh, yes, Pradeep sir, please carry on.
Dr. P.K. Sharma wants to
Yes,
say something. Yes,
Yeah,
yes.
Yes, Mr.
yeah.
Pradeep
Okay,
sir.
I have. Yeah, I have few questions to you. One is now we have four anti-TNF. We have
yes.
secukinumab. In a particular patient, how you are going to select a particular biologic?
So in India, first thing is the cost, definitely. So, initially, if we forget the initial month of loading dose, or some patients we are also not giving the loading dose. So, if you see the long term, secukinumab comes the cheapest. So, even if we taper the biologics in long term, like say adalimumab, we use once a month. Secukinumab, in some of the cases, we have been able to use in alternate months. So, cost-wise, secukinumab comes the cheapest. Second thing is the risk of tuberculosis. So if the Mantoux test are negative, Mantoux quantifier on TB gold and positive, then again, or patient has past history of tuberculosis, then again secukinumab is the choice. Otherwise, I think both anti-TNF or secukinumab scores thing. If a patient can afford, then and Mantoux and TB gold TB screening is negative, then I don't think there is current data to choose one after the another. But cost and TB risk is definitely secukinumab scores more about the anti-TNF.
So next question is about the loading dose. That study you have put it really, that is not a valid study because the response in the placebo group was around 50%.
Yeah, yeah,
So
yeah.
what is your personal take on this avoiding the loading dose? Because of the cost factor, can you do away with the loading dose?
Sir, I had started not giving the loading dose, but then in some of the patients ended up in not having a response also. So that is one concern. In few patients, without loading dose also is effective, but in some of the patients, I mean, those who we have given the loading dose, definitely they say that we felt better.
And
Yeah, so just a comment because I had few patients because of the mainly price factor we have
price
used
factor, yeah.
2 weekly rather than the weekly loading dose, and many patients have responded really well. But few patients we have to change the dose as Abhra said rightly.
So the last question is regarding this uveitis and IVD. So if you see the uveitis study, they were told that I included etanercept also in the TNF, anti-TNF group.
Uh-huh.
So if your patient has prior history of say uveitis, will you use anti-TNF in these patients, say like adalimumab or infliximab or golimumab, or you will use secukinumab if the patient has
Um,
past history of uveitis?
so if it was very recent past, then definitely I would choose anti-TNF. But if it was a long time back, then I guess I would use. I mean, some of my patients I have actually used, and there has not been no recurrence of uveitis. When it is active uveitis, definitely I'll choose anti-TNF, not secukinumab.
And regarding IBD, if you see angstpon, 60% of the patients probably have IBD which may not be symptomatic if you do a
Yes.
colonoscopy. So can that be a factor? Because you have mentioned one study where calprotectin was used, more than 250 and less than 250.
Yeah, I mean, this is a very recent paper where they have proposed, but then I don't know how much useful that would be. So, I mean, most of the patients we don't do a colonoscopy, and many patients with angstpon have subclinical bowel inflammation. So, but then consider other things also have to be considered, like cost. Everywhere the cost becomes a primary factor. So if they have overt history, someone has a history of IBD in the family or some history suggestive of IBD, then I guess we can do fecal calprotectin, and if it's low, then go ahead with secukinumab.
Yeah. Thank you, Jeff.
I think any other questions from the participants? I think there is one question from the for the Novartis guys from Vijay K. Rao. Why not pre-filled syringes in India, and why a powder to our patients? Any comments from the Novartis team?
So hello sir. So actually sir, in the pre-filled syringe, it becomes too much costly for the device, as Dr.
Yes.
Abhra and you all were commenting on that the price constraint issue in India, because it's a self-pay market. It's not a market where the insurers or the third parties they provide. So that is the main reason. We can launch PFS, but the price will go 6,000 or 7,000 maybe.
I think we are coming to the end of the session now. I think Novartis has mentioned few questions, but I think we have pretty much discussed most of it. The first question they have asked is, in India, where we are standing now, the window of opportunity of actual spot treatment. We have pretty much covered most of it. Sir has brilliantly covered that, and Abhra has also covered the medical management part. And again, there was a question: clinical significance of early adoption of IL-17 blockers. So we have already discussed that. Several studies has been discussed now. The question is when to stop biological treatment. Sir, would you like to answer that? Ramakrishnan sir.
That's a good question. If I were to put it a little humorously, because these patients, most of the rheumatological patients, you can't cure them, you can only control the disease. So they come and ask me the same question, how long to take treatment? I say lifelong. Then one person asked me, who's lifelong? I said, since you are the person with the disease, you'll have to take it, you are lifelong. But three things can happen. One, I will definitely die earlier than you because I'm chronologically elder to you. In that situation, you'll have to see another rheumatologist. Very rarely you may die earlier than me, then there is no problem at all. If both of us simultaneously die together, then there's neither a problem for you nor for me. So that is, sorry, a little sarcastic, but still what I just meant to say. The unfortunately, if it comes to the spondyloarthritis, we are still yet to determine the natural cause of the disease because there's a heterogeneity in the presentation, heterogeneity in the disease course, and heterogeneity also in the response. Especially if you take the umbrella on the spondyloarthritis and you take psoriatic lesions also with the various domains, the response keeps varying from one person to the other. We have not found out any ideal biomarker by which you can say that this person will respond and that person will not respond. But what I actually have seen in practice is, there are two objectives. Well, you have the T2T target concept, and then you have the low disease activity. Most of us achieve only low disease activity. I don't think we get into absolute remission as such. So let us talk practically. Science is different, but what do you do in India? That's very important because of the cost restraints. Especially with COVID around, people don't have money even to. It is like ask somebody to take a biologic. It is like asking to people like the French Revolution. The Queen said, "Eat cake when you do not have bread." So, cost it becomes a little prohibitive. But pre-COVID and post-COVID, I'm telling you. Let us take pre-COVID also. That situation. Now, one important fact is that first we clearly do not understand the heterogeneity of his disease course at all. Because in my 35 years, I have seen patients with ankylosing spondylitis doing absolutely normal without any treatment at all. At the other end of the spectrum, you go biologic TNF, no response, you switch to another TNF, no response, then you switch to IL-17, no response. So we have two ends of a spectrum, and in between the majority of patients fall. So one is the heterogeneity of the disease course. So each individual patient is a pearl by himself for a learning curve, and what I would say is called different strokes for different folks. So depending upon the patient's response, invariably I continue my secukinumab definitely for 1 year, and there are some patients in whom I have continued even for 2 years and 3 years. In fact, there is a post-liver transplant patient. I have one person who has started in secukinumab with psoriatic spondyloarthritis, who has done extremely well for the last 4 years. So I feel it is actually individual based decision, not only based on one's experience but also upon the patient's response. That's number one. Number two, after there is achieved a low disease activity, what I do, I space it once in 5 weeks. I do not reduce the dosage. I invariably use only 150 milligram. Very rarely, to be frank, I have used 300 milligram. I have had gratifying response to 150 milligram. Experiences can vary from one person to the other. In very rarely I have gone to 300 doses, like what all you said is cost prohibitive. In fact, people are helpful also to give us the reduced pumps and pump patients, but it's cost prohibitive for people. So the message is, number one, definitely I continue for a year. Most of my patients are for 1 year. Number two, I do not compromise on the number of injections which are given. It is 0, 1, 2, 3, 4, and then once in 4 weeks. It will be once in 4 weeks for 6 months. It will never become once in 6 weeks, or you just give the loading dose up to 1, 2, 3, 4, 5, and then you give it once in 6 weeks or anything. Very important, we should not compromise with the interval, we should not compromise with the dosage, at least for the first 6 months. In the first 6 months, if they achieve a low disease activity, then you can prolong it by once in 5 weeks. If they get the disease back again, then you make it once again in 4 weeks. But I have continued most of these patients on 150 milligrams subcutaneous once in 5 weeks. I never go beyond to 6 weeks, to be very frank. So this is how, and there are some patients who shrewdly stop the injection themselves, and some of them are doing extremely well. But the risk of flare-up after withdrawal of the biologic is nearly 50%. That is an important point. So what is very, very important is patient education in terms of a high retention rate is very, very important with all these biologics. I think, I know this is my personal opinion with some evidence also from literature, but there is no specific guideline or protocol to say you stop the biologic this time, or you, but it is conjectural that we tried, everybody says you would increase the interval, and I found very good response by making it once in 5 weeks. That is my take. There can be objections to it, which is definitely right, because each man has got his own perception. This is what I feel, sir, to be very frank. I may change my thought also after 2 months or 4 months. Yeah.
Okay. Thank you, sir. Any other questions or comments from the audience? I can't see anything else in the chat box. So in that case, I'll probably summarize and come to the end of the session. So we had a very nice, informative.
I think Suman wants to say something.
Sorry?
I think Suman Chakraborty wants to say something.
No, sir. Please ignore. That was by mistake.
Okay.
Sorry.
Okay, that's okay. So I'd like to summarize now. So ANSPOND or spondyloarthropathy is a complex disease. A lot of challenges are there. So early diagnosis and institution of early treatment is the key word. As Sir said, the clinical, radiological and laboratory tests all need to be taken together to get the diagnosis right and the start the treatment as soon as possible. We have various weapons like anti-inflammatories. DMARS doesn't really work. So application of proper physiotherapy, regular exercise and biological treatment we have to use in kind of with the restriction. And that's it really. So patient education is the key. The patient need to know what they have to manage themselves, how to treat the pain, how to carry on with the exercises and take the medications regularly, the compliance issues. And that's it really. Anyways, thank you very much. Thank you, Sir and Abhra, for the nice presentation. Thank you, Pradeep Sharma sir, Parokshit sir, for asking interesting question. I can't see Vijay there now. If Vijay is there, thanks Vijay a lot. If no other questions from the audience, then probably we'll call it a day today. Is that okay?
And thank you, Parthajit, also for that nice moderation.
Yes, thank you, Parthajit. It was a nice day, and thank you, Abhra, and thank you, sir.